After this mesmerizing showcase of Indian cultural diversity, we would be restarting our academic session, and the present session would be on screening and prevention of diabetes. Can we have the chairs? For the chair, I would like to invite for this session on screening and prevention of type 1 diabetes. I would like to invite Professor Maria Craig. Madam is a name that needs no introduction. She is a recipient of various awards and pioneer in various research publications. Madam is president of APIS. Along with her, I would like to invite Dr. Ahila Ayavu. Madam is consultant pediatric endocrinologist and diabetologist at Coimbatore. Madam, I request both madams to kindly take their place.
Whilst we get organised, please take this down because I'm not the star of the show now. Jenny Cooper, as I mentioned earlier, has been an amazing mentor for me. We've known each other, I think, 27 years. And she's been an absolute trailblazer in the world of type 1 diabetes, running multiple cohort studies, but most importantly, the India study, which remains a world first study, trying to understand the interaction between the environment and genetics in the development of islet autoimmunity and type 1 diabetes from early life, so during pregnancy. But that's not Jenny's only claim to fame. She's been involved in many, in fact, led many studies trying to understand cardiovascular disease in type 1 diabetes, including the ADIT study. She was the lead investigator in South Australia, and that was published in the New England Journal. But even prior to that, she's had a really strong interest in a lot of aspects of type 1 diabetes. But today's talk, as well as, speaking off the cuff here, Jenny, but as well as being involved in really important studies trying to intervene in preservation of beta cell function, including the baricitinib study that was published in the New England Journal last year. She has had many academic roles. Oh my goodness, such a great picture. Many academic roles at the University of Adelaide and Women's and Children's Hospital, and she's going to tell me to shut up in a minute, as well as with ANSPED, APEG. But the talk today is really about the concept of screening and prevention of type 1 diabetes, and we really are in a new era, and very much looking forward to your talk, Jenny. Thank you.
Thanks, Maria, and thanks very much to the Scientific Organising Committee. It's a real privilege and honour to be speaking at this meeting of APS and ISPE. It's my first time in India, and I'm really excited to be here, so thank you very much. So I'll be talking about the early stages of type 1 diabetes, some of the screening and monitoring programs we're modelling, particularly in Australia, a little bit about primary prevention, we're not there yet, and the India cohort, which Maria mentioned, and today more the intervention to delay onset of type 1 diabetes, leaving the intervention to preserve insulin production once a child has type 1 diabetes and is on insulin until the immunotherapy symposium a little later on the week on Saturday. So first, the stages of type 1 diabetes. And some of you will be familiar with this concept, but when a person's at genetic risk of type 1 diabetes, some exposure in the environment or a number trigger the immune attack. And once you have multiple islet autoantibodies, we call that stage 1 diabetes now. So rather than So rather than calling this an at-risk stage, we now call this early type 1 diabetes, stage 1, with multiple IgA antibodies. There are no symptoms, and the blood glucose is normal. Through to stage 2, where there's still no symptoms, but the blood glucose becomes more variable, and there's some what we call early dysglycemia, but not yet high enough glucose to fulfill the criteria of diagnosing clinical type 1 diabetes that we're all very familiar with as it presents with symptoms. So these are the pre-symptomatic stages or early type 1 diabetes from stage 1 through to early stage 3. And they can be subdivided again. We seem to love doing that in medicine. Stage 2A and B according to the level of dysglycemia. Stage 3A is that stage we sometimes see when a child is picked up very early, maybe with stress hyperglycemia, but has no symptoms and may not yet need insulin. And of course, the reasons it's important these stages is this is the opportunity to delay or halt the progression on to requiring insulin. And these stages have been embraced internationally. This is the new international code set up in the United Kingdom recently, in April of this year. And just this month, the International Classification of Diseases diagnostic codes will become effective in USA to look at these stages and see them as international classification disease rather than an at-risk state. Now, an important point when considering the development of islet autoantibodies to the insulin-producing cells in the pancreas is that they appear very early in life in really all studies that have looked at this. And from the first year of life, usually peaking in the second or early third year of life. And that, of course, is interesting and begs the question is, does this start in some children before birth? So are the environmental exposures which drive type 1 diabetes occurring before the child is even born if children are getting IgA antibodies from 9 months onwards? And this is interesting age-related appearance of IgA autoantibodies, which is not, in other autoantibodies, which is not entirely understood why, but IgA autoantibodies peak early. Celiac autoantibodies shown there for trans-tissue kinase antibodies in red about a year later. Antiparietal cell antibodies about the same time, and then thyroid autoantibodies appear later, more into the second decade of life more commonly. So because of these early onset of insulin autoantibodies, we set up India, which stands for Environmental Determinants of IgA Autoimmunity, where we recruited 1,500 Australian children who, before they were born, had a first-degree relative, their mother or their father or brother or sister at home, with type 1 diabetes, to determine the effect of early life exposures going back to the pregnancy of the first time on the development of IgA autoimmunity. And as such, it was the first and very much the largest at-risk cohort now following children from early pregnancy. We're proposing that multiple environmental factors, both protective and adverse, may be interacting in early life to increase the penetrance of the risk genes leading to early stage type 1 diabetes. And there's been a large biological sample collection from around the country in Australia, and these are across the child, the mother, the father, and the sibling, and these biosamples are supported by validated questionnaires across nutrition, exercise, sleep, mental health, lifestyle, and also some specific projects within India, such as continuous glucose monitoring in the children who have developed IgA antibodies. And like other birth cohorts at risk in USA and Europe, we've shown that the first antibody is the insulin autoantibody shown in the green, and then that's followed by antibodies to GAD and to zinc transporter 8 antigen, and sometimes in combination. So some children develop 2 antibodies, it seems, immediately. The final autoantibody that we test for, the antibody to IA2 antigen, interestingly, is a very rare first antibody in children in all studies. Now, you can predict risk of progression in several ways, and obviously this is incredibly important when we're looking at when to intervene and who to intervene with. So there's a big difference in your risk of type 1 diabetes according to the number of islet antibodies that you have. So you can see from this chart, the green line represents the risk if you just have a single persistent islet antibody. And you can see that's relatively low, sitting a little below 20% for a lifetime risk, compared with 2 or more islet antibodies where you're getting up to, over time, about a 90% lifetime risk. Hence why we call this stage 1 type 1 diabetes, because the lifetime risk is almost 100%. So it's a very important distinction with the number of islet antibodies. The titer of antibodies is also important. In the top figure there, the orange represents children with a single islet antibody, but a relatively higher titer, and you can see their risk is coming up closer to lifetime 50%. This is a combined cohort study, so there's a lot of children in this study to get this type of data. In the bottom figure, these are all children with multiple islet antibodies, but as you go from green to blue to orange to pink, you increase the titer of the antibodies at the baseline sample. And you can see they've all got a very high risk of getting type 1 diabetes eventually, but the rate of progression is much higher in the children with high titer. So the number of islet antibodies, the titer of islet antibodies, and then, of course, the age, which as pediatricians, we're very used to this concept of a strong age effect in risk for a lot of conditions. So this is data from the Teddy birth cohort across centres in USA and Europe. And the green line are the 3-year-olds, and then you have the blue is the 2-year-olds, and the red is the 1-year-olds. So you can see under 3 is a much faster progression to clinical type 1 diabetes, from single to multiple islet antibodies, sorry. So these are children with single islet antibodies progressing to what we call stage 1 diabetes, and it is much faster in under 3-year-olds. There's also an age effect if you've actually got stage 1 or 2, you've got multiple islet antibodies in progressing to clinical type 1 diabetes. It's not quite so marked, and it's more in the very younger children. You see there in the blue and the red lines, the children under 2. And interestingly, emerging data suggests that once you've got multiple islet antibodies, genetics and or family history really don't impact the rate of progression to clinical disease. They're very important in getting those islet antibodies. Once you've got them, your progression is then determined more on other things, such as age. But we very much now that there looks so to be opportunities to delay the progression to clinical diabetes and requiring insulin, want to often work out for a trial how can we predict the child has about a 50% risk of progressing to clinical type 1 diabetes quite quickly over 2 years, so the trial can have a clear result relatively quickly. And this is some work done from TrialNet, where there's a large number of children with type 1 diabetes that have been followed, and by Carla Greenbaum as the senior author. And it's really called Moving Beyond Staging. So it's showing that there are stages, but what is also important is how old the child is, what the hemoglobin A1C is, and are there other high-risk markers that we can see on oral glucose tolerance tests in terms of glucose and C-peptide. And by using this kind of strategy, you can really quite clearly see risk of progression from stage 1 or 2 diabetes over 2 years to be estimated. So on the figure, the yellow line is actually children with stage 1 and you might not expect them to progress so fast, but they actually have 2 or more risk markers. The children in red are stage 2, and they just have 1 risk marker. So it's really trying to bring everything together to maximise our ability to predict progression, which is so essential if you're going to be designing trials. So now just a little bit about screening and monitoring. The goals of screening, and I know my sort of colleagues in paediatric oncology often say, but why are you thinking of screening? We don't yet have a sure prevention of type 1 diabetes, which is the normal reason we screen for conditions in childhood. But there are 3 main goals that are seen as justifying screening. The first, and perhaps the major one, is the prevention of diabetic ketoacidosis, and I'll show you how screening can do that with follow-up. Secondly, access to increasing numbers of intervention trials to slow down and prevent progression, and often trials where everybody gets 1 active agent and then is randomised to another one, so of benefit to all children. And then the concept of a softer landing with education monitoring beginning well before you have to begin insulin. And all of us who look after children with type 1 diabetes understand just how preferable it would be to be able to have monitoring and education occurring slowly rather than exhausted parents who've just come out of a high dependency unit after e.g. ketoacidosis. Just to remind us that there is 1 country in the world that now has screening for type 1 diabetes in their law now, in Italy. They've been the first country in the world to do this. The other countries are more looking at models of screening and programs for screening. This is the first country to actually have a law for paediatric screening across Italy. So first, the prevention of diabetic ketoacidosis. So here are the list of cohorts, both in the general population and in children with a first-degree relative or at genetic risk, as shown on core blood. And then the middle column is their estimated risk of diabetic ketoacidosis according to the age of those cohorts. So younger children have a higher risk than older children, and the country they come from in terms of their prevalence of ketoacidosis. And on the right, with all these children being followed approximately 6 monthly, you can see the actual instance of diabetic ketoacidosis, and it's slashed down to about 10%. So it really is a dramatic and consistent difference across all these cohorts that has been shown. And this is perhaps a more real-world example, because all these were defined, discrete cohorts all being followed with some loss to follow-up. But this, John Wentworth put together all the relatives in Australia that have been screened for other reasons in trials and TrialNet, and of 17,105 relatives, looked at what had happened. And quite a few of these individuals were not retested for some reason or lost to follow-up. But with 17,000 relatives, of the 178 developed type 1 diabetes, only 5% presented with diabetic ketoacidosis. So even in the real world, when you're losing some families to follow up, we had this dramatic effect on diabetic ketoacidosis. And this is data from the Australasian Diabetes Data Network that Maria Craig is medical director of, showing that in Australia, our rates of diabetic ketoacidosis are relatively comparable with many countries in the world, about 1 in 3, even in people with a family history of type 1 diabetes. So compare that with about 3 to 5%, and you can see that screening and follow-up makes a dramatic difference. Recognising the trade-off between the frequency of following a child with antibodies versus wanting to prevent every case of diabetic ketoacidosis, the TrialNet consortium that I mentioned before, with over 6,000 people with adult antibodies, fitted models to see where's the sweet spot where you only keep a child or young adult undiagnosed with high glucose levels for no more than 6 months, thinking that was relatively safe to prevent ketoacidosis. How many times do you have to follow them up? And it ended about, in the first 18 years of life, about 14 visits, kept the time of not being diagnosed under 6 months. So it's an interesting finding, because if we do come to doing wide screening and monitoring, we'll have to really rationalise how often we have to monitor people to prevent ketoacidosis. We don't want to be over-monitoring them. So the other goal of screening, a softer landing, a more gentle landing for families. Juvenile Diabetes Research Foundation International, now called Breakthrough Type 1 Diabetes, brought together international guidelines in June of this year. And one of the goals of those guidelines will look at goals of education for families and people with early type 1 diabetes. And these goals of education actually rotate a bit around the goals all over of screening, really to educate about prevention of ketoacidosis and the symptoms of early diabetes, for families to understand risk perception, and then thirdly, to understand available interventions and how to access them. These were worldwide guidelines, so they're really reasonably general and not too region-specific in their goals. In India, we looked at the stress levels in the mothers, 900 mothers, in relation to their children's islet antibody status at 4 years of age. And those children who had developed islet antibodies are shown in the yellow on the right, and on the grey are the children who are the majority who hadn't developed islet antibodies. So there's just a little over 100 children on the right. And to our surprise, there really was no difference in the stress levels. But I think this is an example where families have been followed since the pregnancy closely by research nurses who know the family very well, consistency of follow-up. And this would be very hard, or indeed we wouldn't have the resources to replicate this in widespread screening. There is quite a lot of international data on the stress for caregivers, mothers and fathers, of children who develop early type 1 diabetes, and not least of which they actually don't always know how far away type 1 diabetes is. It could be months or it could be years. And generally, most cohorts have shown some increased anxiety, but this anxiety settles so that when the child does develop type 1 diabetes, the family has far less anxiety than community controls who are coming in from the community with type 1 diabetes. Where there's a bit of a gap in knowledge is children's feelings about this. Children from 8 years up are thought to be able to give pretty independent opinions about how they feel about monitoring and tests and being at risk of a condition like type 1 diabetes. And we're combining cohorts in Australia to look at this, particularly looking at the children's feelings with qualitative research. So these are the international guidelines for monitoring individuals with early type 1 diabetes that were released mid-year and was a big worldwide effort. And I think will be very helpful as different countries set up different programs according to what works for their health system. This is what we kind of took out of it for Australia. Really that frequency of monitoring should depend on whether the child's got a single antibody, a multiple antibody, and what their age is. So again, I think of the rule of threes. If a child's under 3, we monitor a little more frequently because they're the ones that tend to progress more quickly. If they've got a single antibody, we'd only monitor for about 3 years because after that, most of the spreading to multiple antibodies has occurred. If they have multiple islet antibodies, again, if they're under 3, we follow them a little more frequently. And of course, if the child on other monitoring, such as random capillary glucose or hemoglobin A1C, or even continuous glucose monitoring, suggests the child's getting closer and has gone to that stage 2, we would monitor more frequently. So stage 2 diabetes, where there's some dysglycemia, more variation of the glucose level, but below the cutoff to diagnose clinical type 1 diabetes and before there are any symptoms is a very important stage, because it does seem to be the stage when we can, certainly with one agent now, interfere and delay or perhaps even eventually prevent type 1 diabetes. So the factors in type 2 diabetes that are associated with progression do seem to be very important for the design of interventions. These children, by definition, don't have symptoms of type 1 diabetes. Their capillary glucose randomly at home is usually normal if tested. Hemoglobin C is found to be very useful if it's greater than 5.7, less than 6.5, which we tend to use as like sort of cutoff for clinical type 1 diabetes. And there's been a rise since the last one. That seems to be a very important factor associated with progression. Oral glucose tolerance tests, much as we don't like using them very much in young children, I don't think we'll be using them routinely, but in research studies, if the fasting levels in stage 2 are less than 7, and at 2 hours, they're sort of 7.8 to 11.1, so not at that criteria of stage 3 where you might need to start insulin. And there's been quite a lot of work on continuous glucose monitoring as to how you can predict progression from it. And while there's been some papers from Denver, Colorado, suggesting that 10% of daily readings above 7.8 millimoles per litre are predictive of progression, our data is a little bit more confusing than that. And I think CGM, continuous glucose monitoring, we're still a little uncertain exactly how to use it for prediction. So this is a child with dysglycemia. Some of you may have seen a continuous glucose profile very like this, where clearly you're not going to start insulin in this child, but there are some blood glucose levels going up above 11.1 intermittently. And this is some work from India led by Dr. Ebony Haynes, where very young children at seroconversion, they're only 2.2 years at median. So this is the youngest study of continuous glucose monitoring in children with early type 1 diabetes not on insulin. So we had 55 children, they had 6 monthly profiles, and these profiles were for 14 days, so they're sort of gold standard. And on the left A figure, you see their mean interstitial glucose measured, and on the right B, you see the time over 7.8 millimoles per litre over the course of the profile. And I think what's interesting is the higher, the purple ones, where you're getting higher for both those things, are occurring a bit more later in the day, closer to the late evening when these children are actually in bed. And we do sometimes see that in young children, don't we, on insulin, or we have higher levels from that time, not always related to food. And the stars, I hope you can see those, they're quite small, but the 4 stars are actually children who progressed to type 1 diabetes clinically and required insulin quite quickly over the course of the continuous glucose monitoring. But I just want to also note, in the bottom panels, which are antibody-negative children, these are age and gender-matched controls, notice that even they, on continuous glucose monitoring, sometimes have slightly higher levels. And we don't think there's anything close to type 1 diabetes of these children. They've got no IAT antibodies. They're controls. But I think it just shows that continuous glucose monitoring does have some spurious levels that come, some postural changes, etc. We tried to exclude those, but we still found these quite interesting results that would be hard to completely hang your hat on, as it were, to know that child was going to progress. And this is breaking up the children on the left panel, children who developed IAT antibodies before 3, and on the right, the children that developed antibodies after 3 years of age. And what I'm trying to show here is that you couldn't just go on one continuous glucose monitoring profile over 14 days, even though it's a lot of blood glucose, interstitial glucose readings when you think of 14 days, day and night. But the children who seem to progress are the ones where there's at least 2 rising. And some children rise up above 20%, above 7.8 millimoles per litre, and then come right back down again. So at the moment, not the easiest thing to predict unless you've got quite a series of continuous glucose monitoring. Now, to get back a little bit now to screening rather than monitoring, and I'm very grateful to Dr. Kirsty Bell in the middle there, who gave me some of her slides, because she was the principal investigator for setting up the national screening pilot in Australia over the last, since 2020. Maria Craig's also been very involved in this, so I hope I'm being true to the to the model, because Kirsty and Maria did a lot of work in relation to this pilot. So the overall objective was to get the best model for screening in Australia. And I sort of want to emphasise, I think it's very important to realise that there'll be different models for different health systems, and just what we find in Australia won't necessarily apply. But I think it's a good exercise to look at how we went about this. First of all, to look at the feasibility and acceptability to families of 3 screening models, which I'll come to. Then we'll have a health technology assessment and economic modelling, which I won't be talking about today, definitely getting out of my comfort zone. And then a sort of a mapping of stakeholder engagement across the country. So there are 3 cohorts. The first cohort had testing of a polygenic risk score or genetic risk score for type 1 diabetes on the newborn heel prick sample. And this was at the same time as the national screening program we have for various conditions at birth in children. So it was a very convenient time. And if they had an increased risk, 10% of the population, they will be followed up with islet antibody testing and then re-screened, and if positive, screened closely. Cohort 2 had the same polygenic risk score, but this time saliva was taken rather than heel prick bug, and it was during infancy, so it wasn't actually at the time of the neonatal screening. And then the third cohort missed out the genetic risk step and went straight to islet antibody testing. And in Australia, we've been looking at, under John Wentworth's leadership, a dry blood spot that you can do at home in the community just by pricking finger, putting on a dry blood spot and measuring the antibodies on that. And the design of this was done very well, I think, was very careful to capture a number of states, regional and metropolitan, and to try and get a very good look at a small area and target areas, and these target areas were each in 2 states for the 3 models. So with the newborns, and we had some great advertising, I thought. These are little cards we put on the hospital bassinets, and then cohorts 2 and 3 for the saliva and the finger pricks. And you can set up these types of checklists, if you like, for what do you need to have yes for to set up a population-based screening framework. And I guess we're still working on some of these within Australia. I mean, I don't think we've still got a scalable test in laboratories that we could cope with a general population screening program yet. We're trying to look and see whether this is absolutely acceptable to target population, including regional and rural and populations with disability. We also need to make sure that it would be equitable and follow up not just the screening, but also the monitoring. If you had a positive test, regardless of where you live, your ethnicity, and your disadvantaged status. And of course, the government would really like to know that it was cost effective, and that work's still in progress. So we're not there yet, and it'll be some years before these things have completely worked out. But the Australian experience so far, from the first look of those families that were involved in those 3 cohorts of modelling, was uptake was best when screening was convenient, and that was when it was combined with the neonatal screening blood tests, not surprisingly. Didn't require you, a letter in the mail, a text from your somebody about something is not as effective as you're sitting in a hospital bed after you've had a baby and you're invited to have screening. Parents actually understood pretty well after some discussion with the researchers, key type 1 diabetes and screening information, which was impressive. The anxiety about screening was low. Whether that will be the same for their anxiety if their child is at risk is a completely different matter, of course, and that result's still to come. Families supported population screening in principle. Optimal model is not yet confirmed, and we're moving closer to general population screening. Now, the final goal of screening, access to intervention trials to slow down or prevent progression. So I'll talk a little bit about prevention, both primary prevention and then prevention a little further down the track where you've got early type 1 diabetes and you want to delay insulin requirements. So back to this diagram of developing the stages to type 1 diabetes. And of course, primary prevention has to get in before we've got stage 1 diabetes, if it's to be primary prevention. And reminding you that it may well need to go back to pregnancy because of this early onset of islet autoantibodies. This is just some children from India. We have in several states a little holiday summer program, holiday science program in the lab, which I think is great. So India has some key investigation opportunities, and obviously its main mission is to be able to inform primary prevention. So the early life determinants, early life immunology, mechanisms of maternal protection, which I'll come to, monitoring and biomarkers once children develop antibodies, and importantly, the perspectives of little children and in relation to this whole business. So I just want to talk a little bit about relative maternal protection in type 1 diabetes, because it's one definite protection factor we understand exists, but we don't really understand why. So by relative maternal protection, I mean if a mother with type 1 diabetes has a child, she confirms less than half the risk of type 1 diabetes than if a father has type 1 diabetes. And so this reduced risk in the child or the adult offspring compared with the father's is both for type 1 diabetes that comes on in childhood and type 1 diabetes that comes on as an adult. And interestingly, this phenomenon's been known for 40 years, but more recently it's been shown that maternal protection or relative maternal protection only occurs if a mother has type 1 diabetes during the pregnancy. So she's developed type 1 diabetes before becoming pregnant, not in mothers who get type 1 diabetes after pregnancy. And there's been thoughts then what is going on in the pregnancy milieu that could be relatively protecting the child, and the mechanisms are thought to be either through beta cell growth, so growth of insulin-producing cells, or some immune tolerance conferred by the mother to the child. And glucose is an obvious one. An obvious thing about a pregnancy where the mum has type 1 diabetes is the glucose is going to be higher, despite the low targets, it'll still be higher than someone without type 1 diabetes. And we're looking at that at the moment. The other thought has been in relation to whether maternal antibodies could somehow cause some tolerance towards the insulin antigen in the child. And there's also been considerations of whether maternal enteroviral infections could somehow protect the child from enterovirus infection, a potential key trigger in islet autoimmunity. We've also, in India, Leon Harrison's laboratory looked at pro-inflammatory changes in the gut microbiome in mothers, and this could also cause some immune tolerance and stimulate the innate immune system. And there's also interest in the fascinating phenomenon of maternal fetal microchimerism and whether that could also cause some immune tolerance. But interestingly, we don't actually know yet what the mechanism, either immunological or epigenetic, is for this well-established relative maternal protection. Just looking at transplacental transfer of maternal antibodies, this is in India, and when mothers have antibodies, and the majority of them do to islet antigens or to insulin itself, they take about 15 months to completely clear from the baby, but we can see no association with development of islet autoimmunity in their offspring. The other environmental exposure, which is clearly related to the risk of childhood type 1 diabetes and is a potentially modifiable one, and I don't think we've done a particularly good job with education here in trying to help this, is early life weight gain and risk of childhood type 1 diabetes. Quite some time ago, we showed in the Australian Baby Dive study that at-risk children have a high rate of weight gain in the first 2 years of life, are associated with increased risk of developing type 1 diabetes. In the general population, from the Frieda study in Bavaria in Germany, it's been shown that body mass index in children predicts progression to type 1 diabetes. And Mendelian randomization approaches have showed that childhood body size directly affects type 1 diabetes risk. The effect of the mother and the father's weight is certainly thought to probably be a factor, but it's less well defined. This is long ago work that we did in the Australian baby diabetes study, but really showing quite a small cohort, very about 500 children, only about 46 developed dietary autoimmunity, that we've got quite a strong risk factor if you do have accelerated weight gain in the first 2 years of life, shown in the children in red who are developing IgG antibodies more quickly. And everything's more complicated these days, I think. And in the India cohort, we're looking now at a more complicated model where we look at the mother in terms of her weight, her diet, and the gut microbiome, and the father in relation to his weight and the gut microbiome. We have decidedly less samples from the fathers, actually, I might add, but perhaps that's just the real life. And then their transmission to the child's microbiome and the effect then of the child's weight and growth, the child's microbiome, the child's diet on the risk of autoimmunity. So we've got sort of 3 pods we'll be looking at in these sort of pathway diagrams. Key to all of this is what is the maternal and paternal infant transmission of the gut microbiome. And Tommi Vasanen in University of Helsinki in Finland has done a lot of work in this area, particularly in type 1 diabetes, and has actually got some of our India samples at the moment to particularly look at the maternal and the maternal transmission to the infant, because you can understand that, and if there is potential to intervene in pregnancy, that will be absolutely key. So what about intervention before birth? We thought about this and sort of designed a study, which actually wasn't funded, but it was a good exercise to go through designing a study. If you were going to intervene, it has to be safe, probably the 3rd trimester, something like a resistant starch that might drive the maternal microbiome to have more short-chain fatty acids. These are the anti-inflammatory products of the microbiome, and transmit these microbiota across to the infant. And this is the gut microbiome, which has been shown to be more protective of developing IgG antibodies. But if you're designing these trials, you need to go back to pregnancy. You'd have mothers with type 1 diabetes and mothers without type 1 diabetes, where the father or the brother or sister had type 1 diabetes. And there's quite a lot of things that are quite complicated. The mother with type 1 diabetes carries the burden of more caesarean sections, more antibiotics, different duration of breastfeeding, more prematurity, as we all know. And these are all things that can affect the microbiome of the infant. So quite a complicated design of the study, and it would need to be a pretty big study to have a powerful outcome. India is also looking at associations between all the omics systems in early life. And this is a real multi-university effort, actually, and an international effort. We've been lucky to have had funding streams for international researchers to take with expertise in particular areas, and we have 6 external groups involved in this, as signals for risk markers and for intervention targets. We're also interested in the exocrine pancreas, because we always think of type 1 diabetes being an endocrine condition as endocrinologists in the pancreas. But there's some information that the exocrine pancreas may not just be a bystander, it may be actually a part of the process. The pancreas is smaller in children with type 1 diabetes, and we've shown this quite clearly using ultrasound. On the left ultrasounds there, you can see a child of age 6 with type 1 diabetes. On the right, a child, a boy, they're both boys, without type 1 diabetes. And that's been shown in a large number on the figure on the right. And also fecal elastase is a marker of exocrine function. Remembering that most of the pancreas size as exocrine is also lower, albeit relatively in the normal range in children with type 1 diabetes. And there's been other work using MRI in older children in USA showing that a smaller pancreas predicts progression to type 1 diabetes. And it may be that combined markers of exocrine and endocrine are important for predicting progression. We've shown in the first year of life, but this is unpublished data, that the fecal elastase levels in children who progress to IRT antibodies are actually lower for the first 9 months, and then they come together. So there may be some ontogeny changes, but there's something probably important about the exocrine pancreas in the development of type 1 diabetes, but again, not completely sorted. Primary prevention trials in progress at the moment are being run by the Global Platform for the Prevention of Autoimmune Diabetes in Europe, led from Munich by Net Ziegler. And the first is a primary oral insulin trial, which is designed to determine if high-dose oral insulin as a tolerizing agent from the first year of life to 3 years of age can induce immune tolerance and slow or prevent the initiation of autoimmunity. And excitingly, those results should be out by 2025. The other study, again run by GPAD, is supplementing very young babies from 6 weeks of age, and they've done an amazing job to actually get this going by 6 weeks of age when the children are being screened for genetic risk on cord blood with a probiotic, Bifidobacterium infantis, and to see if that can delay or reduce the development of autoimmunity in at-risk children. And what's underpinning this trial is the knowledge that this subspecies of Bifidobacterium longum is a very efficient metabolizer of human milk oligosaccharides to short-chain fatty acids, when those are the anti-inflammatory metabolites I mentioned before, which may protect against type 1 diabetes. And in the heat map, you can see that this is quite prevalent during breastfeeding in the gut microbiome of the baby, but goes away after weaning. There's also been a lot of work in relation to potential viral triggers of type 1 diabetes. The TEDdy study, which is a birth cohort at risk in USA and Europe, did a prospective virome analysis, and showed that prolonged enterovirus B infection, so not just one infection or a couple of discrete infections, but a series of infections, was associated with the development of type 1 diabetes. And interestingly, one virus, the human mass adenovirus infection, appeared that it may be protective to a degree, which was a very interesting concept of a protection rather than just an adverse effect of the virus. And this is preliminary data from the laboratory of Ki-Wook Kim and Maria Craig and Bill Rawlinson in University of New South Wales, showing, interestingly, in the India study, that one of the mass adenoviruses, mass adenovirus F, may be protective in the children with IRT antibodies at the time of them developing it. This was using analysis of antiviral serology, so the TEDdy study is looking at the DNA of the virome and the RNA, and this is actually using serology, so completely different methods and potentially some similarity in the result, which is exciting. And meanwhile, the first phase 1 trial of a Coxsackie B vaccine has been completed and published from Finland, and it was successful, and there are plans to proceed into phase 2 trials as a possible way of preventing primary prevention. We may have some primary prevention already at work with rotavirus vaccine. This was a study of looking at the incidence of type 1 diabetes in preschool children before and after the introduction of oral rotavirus vaccination in Australian infants in 2007, and there was a decrease and no change after 5 years. It may be for other reasons, but there was one other study in the USA which had similar results, but we're not sure. Early type 1 diabetes, preventing from here, the child's already got IRT antibodies, you want to delay or prevent the need for insulin. And there are many targets of the immune system in type 1 diabetes. And I'll be talking more about these in the immunotherapy symposium on Saturday. But you have targets of the T cell, the B cell, the beta cell itself, and antigen-specific targets which could tolerize to any of these steps. The studies done in stage 1, type 1 diabetes, which I was involved in all these studies, and they were long studies, they were international, they took about 10 years, they were very expensive, and I guess what they lacked, which we now can design, is really clear ideas of risk of progression. So the oral insulin study for over 10 years shows it was safe, but didn't prevent stage 1 type 1 diabetes from progressing. Analysis may have been that some of the higher risk children may have had some delay. Hydroxychloroquine in stage 1 diabetes, which is, as we know, used for malaria in young children, went down to 2 years of age as one of the youngest children in these trials. Again, didn't prevent progression. The trial was stopped early for futility reasons. And abatacept for delay of progression, again, was safe, didn't prevent progression, but had some effect on endogenous insulin reduction C-peptide. But of course, the groundbreaking study was the anti-CD3 antibody to T cells, teplizumab, in relatives of type 1 diabetes that delayed progression to insulin requirements from stage 2 by about 30 months. And any parent of a child with type 1 diabetes will say, if you could delay my child's diabetes by 2.5 years, yes, please, I think. It was relatively well tolerated, although there was some lymphopenia, and a rash was common during the infusions. And this is quite tough treatment. It's at 12 to 14 infusions, but it was the first disease-modifying therapy in type 1 diabetes and the first to delay clinical onset of any autoimmune disease, and received FDA approval in USA at the end of November, 2 years ago. So stage 2 intervention trials are very hard to do. You need usually several countries to get the recruitment going, and it has been joined by a study in low-dose antithymocyte globulin. But recruitment is still quite hard, and that study has been paused temporarily. So these trials in stage 2 diabetes are being formed by trials in stage 3 diabetes, where someone is relatively easy to find participants for those trials present to us and requiring insulin, and I'll talk more about these on Saturday. So our take-home messages: screening programs are being modelled now in a number of countries around the world, primarily to prevent diabetes ketoacidosis and justifying it on that basis, and to provide access to immune therapy trials. International monitoring guidelines for early stage type 1 diabetes are now available and published in Diabetes Care and Diabetologia in June of this year. The increase we've seen in type 1 diabetes in many countries over the last 50 years is driven by the modern environment. We still don't really have a handle on how to change things and reintroduce more protective factors so we could reduce the incidence, e.g. by about 20%. Autoantibodies appear early in life, so we may have to go back to pregnancy. There's primary prevention trials in progress in Europe, testing a probiotic and oral insulin. The first treatment to delay the onset of insulin, teplizumab, is a real turning point and received a standing ovation at ADA when it was presented in 2019. Immune therapies are increasingly and are really exploding on us, with more and more being tested in recent onset type 1 diabetes, which is exciting because hopefully we can bring those back to more the prevention space than just the preservation of insulin production. So the future does seem to hold promise for combination therapies with multiple immune targets in type 1 diabetes. And I just really want to thank our great India team and our funders, and of course, our amazing families. Thank you.
Thank you so much, Professor Jenny Cooper, for that wonderful lecture. And we are sure that your team will lead the way in trying to find more ways to prevent diabetes and help these families. Thank you so much. It was a wonderful plenary session, and we're honored to have you here. Thank you so much.
Thank you very much.